Bismillah ar-Rahman ar-Rahim. Good evening, everyone. Welcome in the virtual Iraqi vibes tonight. And as Iraqi team, we are delighted to host this activity for this time. And this is actually the first time. For me, I'm Mustafa Al-Shahni, a board-certified neurologist at Diwania Teaching Hospital, and I will be the moderator for this webinar. Today, the supervisor will be Dr. Zana Abdurrahman Muhammad. He is an assistant professor in neurology, and he is the head of the neurology department at the University of Sulaimania and Shah Teaching Hospital, and also he is the head of Neurology Center for Sulaimania Kurdistan Higher Council of Medical Specialties. Hello, sir. How are you?
Hello, Dr. Mustafa. Fine, thank you. Thank you very much.
Thank you.
Thank
Dr.
you.
Zana will lead the webinar tonight.
Thank you very much.
Thank you. And
Thank
the speaker
you.
is actually, do you have any comments, sir? Dr. Zana, you have any comments?
Thank you very much for your arranging this webinar. Dr. Abbas is one of the active neurologists in our field and in our area of neurology working. So I'm glad all you are pay attention for this talk, and thank you very much.
Thank you very much, sir. Tonight, the boss of the Iraqi team, Dr. Abbas Nariman Siddiq. He is a board-certified neurologist, and he is the leader of the ILAE Young Epilepsy section in Iraq. He will tell us tonight about the ASCEND trial, a randomized controlled trial of titration strategies for vagus nerve stimulation in drug-resistant epilepsy. Please, Dr. Abbas, the word is yours.
Thank you, Dr. Mustafa. Thank you, Dr. Sari. Thank you, Dr. Zana. We will start our presentation. I'm Dr. Abbas, as my colleague introduced me. This is Dr. Zana, as Dr. Mustafa introduced, and Dr. Mustafa also our moderator. We will discuss the ASCEND, a randomized control trial of titration strategy for vagus nerve stimulation in drug-resistant epilepsy. This is our outline of the webinar. We start by background. The VNS therapy is the most used adjunctive therapy approved for the management of drug-resistant epilepsy in patients aged 4 years and older, for which the surgery cannot be performed or has failed or is not recommended, which include many patients like when there is impossibility of the skull surgery, or multifocal unresectable epilepsy, or recurrent seizure after surgery, or epilepsy of unknown cause, or the foci near and sensitive area of the cortex, or unclear epileptic focus. All of them are considered as suitable candidates for the VNS. The VNS has a low-risk, minimally invasive extracranial pacemaker-like device, which delivers chronically intermittent electrical stimuli to the left vagus nerve, which in turn stimulate the epileptogenic network and the synchronized aberrant cerebral rhythm automatically at specific interval during waking and sleep state. It is a cost-effective method. Considerable decrease. There will be a decrease in the status epilepticus, emergency visit, hospitalization, and ICU cost for the patient. The stimulator is implanted under the left subcutaneous pectoral area, and it includes a pulse generator, spiral bipolar, wired lead wrapped around the nerve, and handheld magnet with specialized programming software for adjusting the parameter of the stimulation. The procedure will take 1 to 2 hours and is performed under GA by an epilepsy surgeon. Then the parameter will be adapted by a neurologist. In experimental studies, stimulation of the right vagal nerve produced a greater degree of bradycardia. That is why the VNS implanted exclusively on the left side. The device cannot be used in patient undergoing diathermy or cardiac conduction disorder or in those with bilateral cervical vagotomy. And it is not recommended in patients with obstructive sleep apnea, dysautonomia, or COPD. There is low risk of congenital malformation and teratogenicity. And it has very low risk of these abnormality. With modern VNS has a good tolerability to the MRI. Safely, the patient can perform 1.5 Tesla. Also, for the 3 Tesla, if we follow all the instruction given by the LivaNova, which is the brand of the VNS, then the patient can perform the 3 Tesla MRI safely. The stimulator is turned on after 2 weeks from the surgery, allowing for the recovery after the surgery and to differentiate between the cardiac adverse effect due to the stimulation and those secondary to surgical manipulation. We start by we start the introduction of the article. Almost 30 years ago, the VNS therapy launched the modern era of neurostimulation and subsequently grew from an interesting and novel therapy for intractable epilepsy to the most widely used form of neurostimulation for treating drug-resistant epilepsy. Despite being deemed ineffective and safe based on the class 1 evidence nearly 25 years ago, being the only modality of neurostimulation that revised twice by the ANA subcommittees, but we still do not have the specific guideline for its optimal clinical implementation, leading to possible underperformance against its potential and underutilization of the VNS. This review gleaned several cardinal points that stood the test of time of the duty cycles of 30 seconds and on and 5 minutes off, which means that the device will be work for 30 seconds and will be in rest mode for 5 minutes, and stimulus frequency of 20 to 30 hertz, then the output current from 0.5 to 3.5 milliampere. The efficacy of the VNS increases over the first year. Non-responder responder to initial setting may respond to incremental increases in the output current and the DC. So, and the side effects, which include the hoarseness, cough, and throat discomfort, are primarily the function of the output current and pulse width, and usually respond to the adjustment of these parameters. The ANA guideline was focused on the evidence of the patient selection, expected seizure and non-seizure outcome, and the dosing or titration. A determination was that optimal VNS settings are still unknown, and the evidence is insufficient to support a recommendation for the use of standard stimulation versus the rapid stimulation to reduce the seizure recurrence. The author were able to conclude that the population level target of output current of 1.5 milliampere and DC of 70% associated with highest likelihood of favorable response based on a statistical analysis of 1,178 pooled subjects. The closest available setting are the OC of 1.6 milliampere and DC of 60%. Since the analysis revealed that the patient treated longer with VNS were more likely to respond to the treatment independently from the dosing effect, an assumption was that patients who have been continually underdosed may still benefit from achieving the target. Thus, the VNS outcome may be potential improvement with proper implementation and of evidence-based dosing and titration guidelines that remain poorly defined. We need this trial, and we needed to focus that the VNS need more rapid titration to improve its utilization. Zadok et al. Retrospectively analyzed that the aggregated data from 12 clinical VNS studies sponsored by LivaNova from 1990 to 2017 and inferred that the fast titrated patient less than 3 months attain clinical benefit faster irrespective of their age. However, two significant concerns ensued. Only about 1 in 10 of the study were offered this opportunity, resulting from routine clinical practice and a rapid titration protocol, which would improve its tolerability profile and likely increase a comfort of practicing physician remains unknown. Curiously, a rapid titration was even less prevalent in children who are more tolerant to the VNS treatment in these studies. In fact, about half of the patients exposed to a slower titration of the VNS required over 12 months to attain a target dose. And the last two retrospective analyses have been identified a promising destination and implying that arriving at it sooner appear clinically beneficial. The faster titrated patient attain clinical benefit faster, yet a precise journey remain elusive. We need a specific VNS protocol titration. Till now, we have not a specific VNS titration protocol. While it was designed and executed before this pivotal manuscript came to exist, the ASCENT study was designed to fill this gap in practical understanding of the pace of optimal VNS therapy implementation. The method analysis. The ASCENT study was designed to determine whether alternate VNS therapy parameter programmed during titration period can safely accelerate adaptation of the VNS tolerance and thereby shorten the time required to achieve a target dose within a specified time frame. The study was conducted between March 2015 to October 2016. And the post-market double-blind randomized trial studied VNS titration in a population of subjects 12 years and old with refractory focal onset seizure treated with the VNS therapy. Participants were followed for 12 weeks after the implementation to determine the likelihood that they would reach the labeling defined targets VNS setting after following one of the three different titration protocols that set to the study. Safety and clinical outcome were collected over the course of the study. The ASCENT was conducted in compliance with multi FDA and good clinical practice parameters. The ASCENT aimed to enroll 60 participants indicated to be treated with VNS therapy. The decision to treat the VNS has been made independently of and prior to the participation in the study. Patients aged 12 or more are eligible for the enrollment, and the patient and their caregiver must have been willing and able to give accurate side effect report, global impression data, and complete study questionnaire and survey with minimal assistance throughout the study. The patients were not eligible for the enrollment if they used or expected to use short wave microwave therapeutic ultrasound diathermy, expected to undergo an MRI with a body coil for transmission of the radiofrequency during the clinical study. Patients who had progressive neurological condition are also excluded. 76 patients screened for the ASCENT trial, 62 patients eventually being enrolled and randomized into the intended to treat population, which we will show on the figure 1. These participants were randomized into 3 groups, A, B, and C, and that defined that titration strategy each participant received. 57 patients completed all study visits per protocol. This is the diagram shows how the patients are enrolled and excluded from the study. The primary outcome measure, the data collected in this study were not used for specific seizure-related efficacy determination. The primary efficacy outcome measure and achiever rate was defined as the proportion of patients in each group who reached the target parameters during any of the post-baseline visit. So the patient should complete the parameter till the end of the study. Safety was summarized based on the incidence of adverse events, serious adverse event, and unexpected adverse device effects. The adverse events that occurred during the study were coded and tabulated utilizing the MED-DRI version 17. All adverse events were followed by the site investigator until resolution, and the study sponsor was notified within 24 hours of detection on any of these side effects. Site investigators were also responsible for reporting these events to their respective IRB in accordance with the institution and regulation. Secondary outcome measure are included evaluation of the time required in each VNS therapy titration group to achieve 1.5 milliampere 20 hertz and 500 impedance DC comprised of 30 seconds on and 5 minutes off. So all the groups at the end should eventually achieve this parameter. Evaluation of differences in tolerability of the VNS therapy in the each groups, evaluation and comparison of the adverse events that occur in each groups, evaluation of the VNS therapy effectiveness for non-seizure outcome between these VNS therapy titration group using the following scale, which will be discussed later. Collection of the primary outcome measure of the achiever rate and adverse event were collected at all study visits. Collection of the CGI and the quality of life scale were collected only at the baseline and 12 weeks after the implantation. Patient satisfaction survey were also collected as an additional exploratory outcome measures. The group definition on VNS titration, the patients were randomized into 3 groups as we said by a third-party statistical program using a predefined randomization schedule. Participants in each group were titrated according to a specific protocol, but all participants were required to achieve the following setting to be considered an achiever of the target dose. As we said, at the end of the study, all the groups should attain the standard parameter of these parameters, as we say. This is the titration. This is the group titrations as we show here. The OC of the group A at initially there is 0.25 milliampere and signal frequency of 20 hertz with pulse width of 50 and on off of 30 seconds to 5 minutes and at the initial step. Then this is the target. From the beginning, the A group set it for the target, except for the output current. Then the group B, we started with low output current and low signal frequency with low pulse width, but with on-off cycle of like the target, like the A. But in the group C, same on the 3 phase parameter, but the last one, there is shorter on-off duration. And the second phase, there is only, in the group A, there is only increase in the output current, but the group B has increase in the output current and decrease of to 2.5, then decrease it, and after the phase 1 and the phase 2 decrease it to 1.5, and increasing in the signal frequency and pulse width. With the group C, the patient output current phase 1, we increased the 0.5 milliampere to 2.5, more than the required for therapeutic dose, then decrease it to the required therapeutic dose with increasing of the signal frequency and pulse width as tolerated. Lastly, in the group C, there is change in the modifying the duty cycle. They change this duty cycle to the standard one. And participants in group A were set to parameters identical to the final target, as we say, with the exception of the OC, which started at 0.5 milliampere, as we said. At each study visit, the participant had their output current increased to the maximum tolerable output current at that visit. Participants in group B and C followed a similar titration schedule. However, they started at lower signal frequency of 5 Hz and lower pulse width. And in group C, the patient also had a variant of duty cycle of 4 seconds on and 1.5 minutes off. In this group, the patient were required to achieve the output current of 2.5 milliampere before titration these and other VNS parameter to achieve the target setting for the signal frequency, pulse width, and DC current. A higher interim target of output current of 2.5 was intended to account for to reduce the pulse width of the rationale behind the starting the setting in these groups hinged on an anecdotal report that lower signal frequency and pulse width are more tolerable for the patient. The initial, as we say, that these two parameters are the responsible for the side effect of the hoarseness and cough. The initial DC setting for group C was considered with the investigational VNS setting for heart failure and was supportive of rapid titration in that patient population. The statistical analysis, the sample size estimated for this study was not based on a formal statistical power calculation. The study defined three populations: intention to treat population, safety population, and the completer. Most study outcomes were assessed on the intention phase population, intention to treat population, and randomized to a treatment group attended at least one successful adjustment of the VNS therapy system parameter. The safety population included all participants implanted the VNS device. The completer population the patient who are completed every study activity per protocol and is not examined in this study. The primary outcome of achiever rate was defined as the proportion of intention to treat population in each VNS titration group that reached the target parameter during any of the post-baseline visits. A non-achiever was any patient where the target parameter were not reached at any post-baseline visit. Achiever rates and the associated confidence interval were calculated at 2, 4, 6, and 8, 10, and 12, and analyzed for group-wise trend. Also, the cumulative achiever rate defined as the proportion of the achiever up to a particular visit and their associated confidence 95 confidence interval were also calculated at same weeks. Secondary outcome measures were analyzed within the intention to treat population. Statistical comparison were conducted to test the differences between treatment group A, B, and A and C, but these tests were considered as exploratory, as the study was not sufficiently powered for these tests prospectively. Time until achievement is based on the achieving target parameter setting, the first targeted parameter that we say. The time until achievement was computed as the date a participant achieved the target parameter setting and sent home the first time minus the implanted date in week. Kaplan-Meier analysis was used to compare the response experiences of patients in the three treatment arms. Patients who discontinued early were excluded or censored on the last visit date. A programming event was assessed. estimated population of achiever rate and their associated 95 confidence associated are estimated on this week based on the Kaplan-Meier model for each treatment arm. Patients who did not achieve the target setting by the end of the study were censored. On the last visit date, the achievement assessment was recorded. The quality of life in epilepsy inventory consists of 31 questions divided into 7 multi-item subscale, which include the emotional well-being, social function, energy, fatigue, cognitive function, seizure worry, medication effect, overall quality of life. This score is obtained used a weighted average of multi-arm scale score and was computed at baseline and the 12-week for each patient. There is a descriptive statistic of the overall score were calculated for each treatment group at the baseline and 12-week. An ANOVA was performed to analyze change from baseline for Group A versus the Group B and the Group A versus the Group C with baseline score as a dependent variable in the model. Number and percentage of global improvement categories are presented for each treatment group at 12 weeks. The VNS satisfaction survey consists of 6 questions aimed at ascertaining the participants' acceptance and tolerability of the therapy were collected in each treatment group at 12 weeks. These data are presented as a ratio of participants who responded positively to each group, to each question. The result on the 15 sites recruiting for this study, 14 enrolled at least 1 patient. Following screening, 65 patients were enrolled, 62 participants were both implanted and randomized into the 3 treatment groups, as shown in the figure 1. Of the 3 patients not included in the intention to treat population, 2 failed to receive implant because of the insurance coverage, while 1 receives implantation but was not set to the correct setting for their treatment group after randomization. This participant was included in the safety population, that one that is excluded. The 5 participants exited the study. 1 was lost the follow-up, 3 withdrew their consent, and 1 was withdrawn by the site investigator after identifying the incorrect device has been implanted. The average enrollment per site was 4.6. Participants' demographic are displayed in table 2. We will show it later. In the demographic data, there was no significant difference between the treatment group at the baseline, with the exception of the prevalence of anxiety disorder, which had a higher prevalence in the Group C. And generally, the participants were white Caucasian adult with the drug-resistant epilepsy with an average age of 37. Most participants has been living with epilepsy for over 10 years, and their seizure has failed more than 3 anti-epileptic drugs prior to the enrollment. There were a greater number of female participants in this population. As we say, this is the age of the patient, 37, more female and white or Caucasian, with more than 3 anti-seizure medication failed. And most of the patients had no previous brain or epilepsy surgery. Clinical outcome, the cumulative achiever rate and the time until achievement. Overall, 39 participants were able to achieve the target setting by 12 weeks. Participant in Group A had the greatest likelihood to achieve the target setting by 12 weeks, and nearly 82% of the participants in Group A achieved the target dose. Participants in Group B were less likely to achieve the target dose by the end of the 12 weeks, while those in the Group C demonstrate a cumulative achiever rate between the Group A and B. Participants in Group B and C were more likely to achieve the target dose later in the titration process. Over 60% of the patients in Group A achieved the target dose by week 8. Time to dose of the group B and C were effectively identical, while participants in group A were more likely to achieve the target dose by the 12 week. Participants in group A were likely to achieve the target dose about 4 weeks earlier than the participant using the than the other, as we see. And by the 8th week, they achieved the target dose. Median time to dose was estimated for group A as 8.5 weeks, and for the group C as 12.6 weeks. This is the percentage of the group A which achieved by the 12 week the target dose, 84%, and in the group B 49%, and group C 40%. This graph shows the estimated proportion of patients achieving the target dose, which clearly shows that the group A achieved the target dose earlier than the other group. The safety outcome. Overall, 69 adverse events were reported during the study, reported by 25%, 25 participants, 40% of the participants. Adverse events were reported at similar rate in each treatment group, with group A and B and C reporting 24, 24, 20 events respectively. Nearly similar rate of adverse event between the groups. In each group, 33 to 45% of participants experienced an adverse effect during the study, while group C experienced a similar number of total adverse events as the other group. It is worth noting that the participants in group C were less likely to report adverse events that were determined to be device or stimulation related. They are reported more non-device related adverse effects. The most common adverse effects reported were consistent with the real-world experience of the VNS, which are included the cough, voice alteration, general discomfort, and hoarseness. Tolerability was assessed independently from the adverse event. Tolerability assessed acutely as the programming settings were adjusted in the clinic. Thus, the adverse effect related to stimulation can be considered tolerability issue that did not fully resolve during the office visit. Yani, if the tolerability mean the adverse effect that occur at the clinic, if it's remain after that, then they regard it as adverse effect. The fact that there were more tolerability issue than adverse event reported indicates that most tolerability concerns resolved during the office visit. Most of the patients were able to proceed with the titration on the schedule. The presentation of tolerability concern following VNS stimulation were similar to the most common side effect of the VNS, as we said, the same adverse event. Participants in group A and C reported a similar number of tolerability concern, while the group B reported a greater number of these tolerability issues. One participant reported a serious adverse event during the study, which was a non-healing wound, but later they assessed it to be due to other causes of severe obstructive peripheral vascular disease of the within the superficial femoral artery, not related to the VNS. The quality of life in epilepsy inventory, which was collected from all but one participant who instead completed the quality of life 48 because of his age, it has a criteria. All treatment group experience a statistically significant and clinically significant improvement in the overall score from the baseline. There was no significant difference between the groups. This is the chart showing there is a significant improvement clinically and statistically, but there is no difference between the group from this. Clinical global impression scale were collapsed from on the 7-level scale. They put it as improved versus worsened scale, 2 for the easy of viewing for the reader. Data were missing in 3 participants coming from group A and B. Participants in group C were less likely to show an improvement and were more likely to worsen. Outcome for group B were similar. 80% or more of the participants improved compared to the baseline. As we showed, there is improvement in the group A and B, but there is less improvement in group C, and the clinical global impression scale, and more worsening of the group C. The patient satisfaction, participants in group B and C tend to report a greater satisfaction with the VNS therapy than participants in group A. The most notable difference between the groups was on the satisfaction with tolerability. All but one participant in group C reported favorable responses, whereas 70% of the participants in group A and B reported favorable responses. This outcome is further supported by the adverse event profile. Participants in group C reported the lowest number of device or implantation-related adverse effects. This is the overall satisfaction. All of the patient has a good overall satisfaction, especially in the group B and C, but more less in the group A. Same change in the total health and well-being, same for the group A is lower than other groups. And satisfaction with tolerability was highest in between the group C patients. This is the adverse event with titration according to the each group titration schedule. As we saw, the group C reported least device-related adverse event than the other groups. The discussion, the E4 ASCENT study is the first post-market double-blind randomization trial of VNS therapy aimed to evaluate feasibility of achieving the target device setting, the standard target, within 12 weeks through 3 different titration schedules. To explore the practicality of reducing the time required to titration the VNS therapy and to the target dose range, given that evidence from clinical practice suggests that faster titration is associated with highest likelihood of becoming a responder, more than 50% reduction in the seizure frequency quickly, less than the proposed duration, the practical one for now. Yet the same real-world data should indicate that nearly half of the patients are not at the target dose within the 12 months after the implantation. So most of the patients, when we implant the VNS, most of the patients, they say, I didn't get benefit, but really they need more time to achieve the target dose. This may be indicative of considerable underutilization of the clinical potential of the VNS therapy. This suggests that the actively treated patients with VNS therapy are underdosed, and so they are undertreated. The combination of the output current and pulse width define the amount of charge delivered to the nerve and indicate the likelihood of achieving an effective activation of the vagus nerve. When thinking about attaining full, sufficient, and effective or optimal activation of the vagus nerve, one must not forget that it requires selection of the combination of VNS setting according to the individual patient and their unique tissue properties, electrode position, seizure type, comorbidity, ability, readiness to tolerate the stimulation and the side effects. The ultimate goal is maximal lasting therapeutic effect with minimal side effects. Having multiple VNS parameters available make it more challenging to define their optimal combination that will produce this kind of stimulation as a target dose. While the tolerability of a therapy as its target therapeutic dose is important to patient care, failing to achieve the therapeutic dose subject the patient to a potential risk without the opportunity for the benefit. especially for device-based therapies like the VNS. The more the threaten the health risk, like infection from the surgical procedure, is the more risky than the the risk is not from the intensity of the stimulation. It has low minimal side effects on the voice or cough. Implanting the VNS without following to reach a therapeutic dose should be considered akin to subjecting a patient to sham surgery. It will be meaningless if we didn't have reach a therapeutic dose, which is only considered ethical in the context of clinical investigation, not clinical practice. We hope these findings will increase practitioners' zone of comfort and reduce the likelihood of encountering patients with uncontrolled epilepsy, whose the output current is below 1 milliampere, even a few years after implantation. Some patients may be clinically respond below the 1 ampere, while others need more than 1.5. If we talk about the practice, most patients respond to 1.5 milliampere. However, it is worth mentioning that the parameter selection for titration of group B and C has lower frequency and pulse width, are widely believed to be more tolerated by the patient, supported by the finding of the study. Historically, the VNS stimulation frequency was between 20 to 30, which has been used in clinical trial. In the epilepsy, 30, and in the depression was 20. Over time, the standard VNS frequency for the epilepsy has become migrated to the 20 hertz, so much so that it is now the default signal frequency for the new VNS devices. This shift within the modern frequency range has not been accompanied by any perceived impact on the efficacy, at least at the population level, but has been accompanied by a greater tolerability. In this study, the patient in group B and C experienced lower stimulation frequency, as you see, 5 Hz, at the beginning of their titration protocol and later shifted to 20 Hz. While this decision was made to improve the tolerability, while the output current was increased more than the recommended dose at the beginning. It is important to recognize that the decision to use signal frequency outside the recommended range had not been thoroughly explored for the chronic treatment of the epilepsy. In fact, case report including human hippocampal EEG has shown decrease in interictal epileptiform discharge at 30 Hz stimulation, while the VNS at the lower frequencies of 5 Hz had the opposite effect. Early studies of VNS in animal model of epilepsy indicated higher frequencies, more than 10, up to 20 Hz, to have superior anticonvulsant effect when compared to the lower frequencies. But there is limited understanding of the fact of signal frequency selection on the epilepsy outcome in humans. While there was no unexpected adverse effect reported, the stimulation adverse effect outnumbering the implantation adverse effect as reported by only 40% of participants. Thus, most adverse effect encountered in our study was the hoarseness, cough, voice alteration, and general discomfort. Parallel clinical practice experience where they are much more likely during the titration phase and often diminished with time. Assuming VNS is akin to drug titration, we would intuitively expect an inverse correlation, at least between the stimulation adverse effect and the achiever rate in this trial. Group B had the lowest achiever rate, but the highest proportion of participants reporting a stimulation adverse effect. There was no such inverse association of dose achievement and stimulation adverse effect in Group A and C. In fact, the Group A reported overall most adverse effect and had highest achiever rate. While we cannot explain these findings completely, it seems that a much finer capturing and analysis of the adverse effect will be necessary to reveal if presence of any adverse event may have prevented further titration toward a target as opposite to only a moderate and or severe adverse effect. So we must consider the personal sensitivity and of the patient or caregiver motivation. Prolonged psychological factor may be a key, important factor. Also, we have a patient who may not accept the mild degree of hoarseness without any hesitation, but some others may insist on extreme steps such as device inactivation. So it may be a personal diversity between the patients. Improvement in the various aspects of quality of life with epilepsy or depression treated with VNS is solidly reported in the literature. Anecdotally, more energy or better mood may be first feedback to a clinician from a newly implanted patient. It may be worth noting that the author would have a very hard time recalling a patient claiming the same after starting a new medication. So has this benefit over the medication, which improve the mood of the patient. Consequently, it is not surprising that all treatment groups experience a statistically and clinically significant improvement in the overall quality of life score from the baseline. And the global clinical global impression scale is a simple scale on which the patient rate subjectively has a total clinical improvement from their baseline, irrespective of their perception of its association with an intervention. In our study, about 80% in group A and B reported an improvement compared to baseline, while participants in group C were less likely to demonstrate an improvement and were more likely to worsen. Interestingly, the same number of participants in Group A and C reported that they had no change. Considering that Group A include the highest achiever rate and Group B the lowest, it's safe to infer that CGI score is not driven by dosing alone. Curiously, Group A and B had a similar number of total adverse effects. When it comes to patient satisfaction, participants in Group B and C tend to report greater satisfaction with the VNS than the Group A. The most notable difference between the group was on the satisfaction with tolerability, which had all but one participant in Group C reporting favorable responses, whereas 70% of participants in Group A and B reported favorable responses. This outcome is further supported by the adverse effects reported in the study, as Group C participants experienced the lowest number of device or implantation-related adverse. The titration algorithm described in the manufacturer's labeling, which is also pre-programmed into the guided programming and scheduled programming feature on the most recent VNS generator, Sentiva, is the Group A protocol. This is the latest program. This study suggests that more than 80% could achieve the target setting in 3 months if this protocol is followed. Yet, product surveillance indicate that 50% of patients in the US are not at the target dose within 12 months after implantation. This is a solvable problem by scheduled programming can even offload the burden of bi-weekly visits in the office and required to follow this protocol precisely. Importantly, the participants in Group B and C were titrated at lower pulse width and very low signal frequency that is practically not used in the clinic, and were forced to titrate it initially all the way to 2.5 milliampere before lowering the current to the target dose. It is possible that different titration scheme that allowed for more setting to be changed at once rather than output current phase, then the pulse width, then other setting would have allowed these participants to be titrated faster. So we have many parameters in the VNS. We can change them interchangeably. In short, it is critical that practitioners realize that the VNS titration timeline can be shortened drastically and safely to decrease a seizure burden and preserve a brain reserve while improving various aspects of patient life. Although prospective blinded randomized trial, the study, but has a few limitations. The group size was not a product of power calculation, but rather than an empiric heuristic, except for Group A protocol for which pre-existing evidence from epilepsy field was available. The other group titration scheme were more convenience choices based on different contexts, not reflective of clinical epilepsy practice. Subjective scales were used and their result may be affected by many factors that cannot be accounted for. We do not have befitting account for a reason that prevented reaching target parameter among some of our participants. In conclusion, this study proved that achievement of adequate dose of VNS therapy at dose that is associated with ideal therapeutic outcomes in most patients is possible in 3 months or less for most patients. Patients who receive regular increases to VNS intensity, while other stimulation parameters are held constant at the default setting, are most likely to achieve this target dose of 1.5 milliampere and the other parameter that we said with the 30 second on and 5 minutes off. This titration protocol, now in VNS programming parlance as the standard protocol, can be automatically implemented on more recent VNS models through scheduling program. Thank you.
Thank you very much, Dr. Abbas. You did very well, my friend.
Thank you.
Before we go, I would like to remind attendees to fill out the post-presentation survey. And actually tonight we had more than 40 attendees, but only 4 questions so far. But before we go, I would like to move to our supervisor. So Dr. Zana, if you have any comments about the presentation. I guess Dr. Zana is not there. So now we will go to the questions. The first question, Dr. Abbas from Majda Lutfi. She asks about the security X-ray scanners in malls and airports. Are they safe for those patients who have VNS? And also for the CT scan, is it safe to have a CT scan in a patient with a VNS inserted?
Yes, it's safe. There is no any guideline mentioned that they are not safe. X-rays and CT, they are not they are safe.
Okay, thank you. And another question we have from Pedro. He is from Brazil, and he asks, is it possible for those patients that went VNS treatment to be seizure-free after years of VNS stimulation?
Yeah, as we said from the study that showed, and that showed in the most of the other studies, the VNS patients will increase their response rate after year. So with time, they have more response rate. It's possible, yes.
I think he mean, I'm not sure, but I think he mean, is it treatable? So when the patient decrease seizure frequency, we can remove the device or we can turn it off?
No.
So it's my question actually. Pedro
yes,
didn't say that.
the VNS put it for a patient with drug-resistant epilepsy. So already the patient tried more than 3 medications that failed. Then we add the VNS as an adjunct to the medication. Many of the patients will have only reduction in the medication with the VNS to control their seizure. but most of the patients, they need to continue on the VNS, long life.
Okay, another question from Pedro too. He asks about the deep brain stimulation. As we know, he says it has been a study stating that deep brain stimulation can be used for epilepsy. So do you think the VNS works better than DBS, deep brain stimulation?
I think that this discussion is out of scope, but shortly I will answer it. The DBS has a specific indication for like in the thalamic based epilepsy. Not like the VNS. The VNS is more in the multifocus, non-operable cases. Yeah, their indication is different.
Okay. And the fourth question, is the effect on seizure rate if the VNS stimulation turned off, like
Sorry,
when the battery is died?
I didn't understand the question.
He said has been turned off. So is there any effect on the patient? Like the seizure frequency will increase or?
Yes, if the device turned off, you mean? Like when the battery, well, need change?
I mean, if the VNS device turned off, the seizure frequency, will it
Yes, could be
increase more
increased.
than the pre-treatments?
Yes, could be. Yes, definitely could be increased. So it need to.
I think he's borrowing the concept of withdrawal seizures. So do you think
Yes,
if the patient had turned off his VNS, the seizure will break through?
yes, could be, but it changed accordingly according to the patient.
Okay. And another question from Nada, she asked if the titration protocol depend on the seizure type or the epilepsy type, whether focal or generalized.
And this study, they didn't depend on the seizure type. They are all focal cases that are drug-resistant epilepsy. All of them are focal, so they didn't test the generalized type.
Okay, thank you, Dr. Abbas.
Thank you.
We just want Dr. Sally to give an input. We missed you, Dr. Sally. Are you there? Oh, I think she is not.
Yes.
So thank you for attending.
Thank you.
Thank you for waiting for the end of the
Thank you
webinar.
for listening.
Thank you very much.
Thank you, Dr. Mustafa. Thank you for everyone.
Thank you.
Thank you.
Bye.
Good
Have a
night.
good night.